But I do want to thank them for inviting me to participate in this conference. It's always great to get away from the East Coast. We still are having some cold weather. And this is an important slide anytime we talk about ACS. I'm not paid by pretty much anybody, barely by university, but I'm not paid by any drug companies or device manufacturing companies. And our objectives for the next 20, 25 minutes or so are very simple. You know, there's a lot of fancy CME objectives that you always get, but I only have two objectives here. Number one, we're going to talk about a few things that you need to know to better protect your patients. And also, it's very important to remember that in our society, every time there's a healthcare provider-patient interaction, there's actually two people at risk, right? It's not just the patient, but we're at risk in the society also. So we're going to talk about a few things that you need to know to better protect yourself as we go through this as well. We're going to protect ourselves from these guys, the lawyers that are out there. This is Johnny Cochran. Some of you from California may know. I don't think he's still alive anymore, but anyway. But nowadays, it's a matter of protecting ourselves from the media as well. And it's really unfortunate, but the media has really gotten into this as well. The media love to go after doctors for a number of different things. This is the front page of the USA Today from 2006. And there was a man who showed up in an emergency department and was misdiagnosed. He ended up going home. He died. And his wife made a big campaign of the whole concept of misdiagnosis of acute MI. The emergency physician who took care of him is listed on the front page of the USA Today, right? Cardiologist is one of the inside pages. So how'd you like to be on the front page of the USA Today for something like that? The paramedics, I don't know if there's any paramedics here, but you guys are at risk as well. This is the front page of the Washington Post online section where they ran a story about paramedics that misdiagnosed a patient with reflux. We'll talk more about reflux also. So it's very important that you know things that are going to help your patients, but also to help protect yourself as well. The outline is very simple. We're going to run through and try to bring everybody up to speed with the current ACC/AHA guidelines for non-STEMI ACS, as well as STEMIs, and also the guidelines that relate to percutaneous coronary intervention. You have a handout which is very comprehensive. It's about a 15-page handout or so in which I've summarized all the major guidelines. Please don't follow in the handout, okay? The handout is intended for your reference later on. I'm not going to follow the handout word for word by any means. I'm going to try to highlight some of the important details. And also that statement applies for all of the lectures I'm going to do this morning and after lunch. The handout is for your reference. You guys are going to have access to the slides, and you can refer to the slides if there's any questions. But the handout's very comprehensive, but again, are intended for your reference. And also, don't worry, we're not going to spend a lot of time focusing on the research aspects of what we've talked about. We're going to spend time talking about some of the important takeaway points and also some of the risk management points as well. We're not going to get through everything probably, but again, we're going to try to focus on some of the key elements. So let me start out by just posing a simple question. What's the most common misdiagnosis sitting on the chart of a malpractice case against an emergency physician for a missed MI? Just shout out an answer. Reflux. I heard reflux, a few people said. Absolutely gastroesophageal reflux. So first takeaway point, we're going to start the day with a really, really important takeaway point. If you do what I'm about to say, you will prevent many lawsuits during your career and against your colleagues. Every time you write reflux on the discharge papers for a patient, slap yourself, all right? If you do that, you will prevent lawsuits. Now, I'm not saying that reflux doesn't exist, but there are many, 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 many cases of missed MI which are diagnosed as reflux, and emergency physicians and a lot of cardiologists also get burned over and over and over. So why is reflux so commonly misdiagnosed? Well, if you look through the literature, a little bit of focus was in the guidelines, but I think this is so important. I want to go outside those guidelines to talk about this. If you look at the literature, 8% of MIs, the pain from an MI, begins while somebody's eating. So Mr. Jones is just sitting down for a meal, he's eating breakfast, his oatmeal, and boom, his pain starts, or maybe some spicy jambalaya, which makes us think this must be just reflux. All right? What else? 20% of MI patients and unstable angina patients will describe their pain using the word indigestion. In fact, there's 2 articles from the cardiology literature which looked at all the different descriptors that people use to describe their MI pain. Sharp stabbing, pressure, squeezing, tightness, indigestion. In these 2 articles, what they found was that if a patient uses the word indigestion, it has the highest likelihood ratio for ruling in for an MI, believe it or not. All right? So be very careful about that word. That's a dangerous, bad word. It should be 4 letters, actually. 15% of patients with an MI get some relief. 7% of patients will get complete relief of their MI pain from Maalox or Zantac or some other type of antacid. Again, making us think about this. Almost 50% of patients having an MI will report that they had an increase in belching during their pain. And maybe that's from diaphragm irritation from an inferior MI. I'm not really sure. But another reason why we tend to misdiagnose these patients. And finally, literature going back to the 1960s indicates that true reflux does exist more commonly in coronary patients, just to make it more difficult for us. And if you wanted to really diagnose reflux, what you do, get a GI doc to put an esophageal probe down, a pH monitor, into somebody's esophagus, and when the person has episodes of reflux, you'll see the pH drop because of the acid production. So true reflux measured by pH probes occurs more commonly in patients that have underlying cardiac disease. Right? So there's a lot of reasons why we tend to misdiagnose this. Please remember this slide. All right? And every time you write reflux, please just think twice. Think 3 times before you send that patient out. All right? I do a lot of medical legal reviews and see a lot of missed MIs. The 2 most common reasons in the year 2009, 2010 that I see malpractice cases against emergency physicians and cardiologists for missed MI is overdiagnosis of reflux, by far number 1 reason, and then number 2, over-reliance on previous negative cath and stress tests. We'll talk about that briefly in just a minute. Okay, so talking about ACS evaluation, and here's another question, and this goes in the guidelines, a little bit beyond the guidelines also. When is a coronary plaque at risk for rupture? Well, I'll tell you what I learned back when I was in medical school, residency. I learned that plaques that are at risk for rupture are big plaques. 70, 80, 90% size plaques. Those are the ones we need to worry about. Some people now say, well, maybe 50% is when you got to start worrying. Okay? That's all myth. That's what we now know. It turns out that the chance that a plaque has of rupturing is not related to size, but it's related to composition. Specifically, it has to do with the thickness of the fibrous cap on the plaque and also the lipid core. Here's another interesting point that we know is starting to make its way to the EM literature now. And in fact, it was on the EM in-service or boards about a year or 2 ago, so you'd say that this should be common knowledge in emergency medicine. 2/3 of MIs occur in patients whose infarct-related artery was less than 50% occluded before it ruptured. So those 70 and 80% size plaques, those only cause 1/3 of MIs. 2/3 of the time, they're plaques that are less than 50% occluded. And if that person recently had a negative cath, how is that cath read? Non-significant size occlusion. All right? Be very careful about that. So this is a nice little model of what we've traditionally learned about plaques. Again, I'm going to go through this quickly, but this is an 80% size lesion. We used to think that this is the plaque that causes MIs. Here's a 50% size lesion. All right, this is the 40, 45-year-old patient, 50-year-old patient who's doing well, probably jogs on a regular basis. Like, remember Tim Russert, negative stress test. He was on his treadmill the morning he died. Okay, what we now know is that this is the unstable plaque. And the reason this is unstable is because it's got a thin fibrous cap and a large lipid core. It's the composition, not the size of the plaque. And by the way, this is the type of plaque that gives you a negative stress test. This is the type of plaque that oftentimes gets read on cath as non-significant size lesions. This is the type of plaque that causes 2/3 of MIs in our population. All right? Another concept, coronary artery remodeling, which the guidelines just touch on. This has become a very hot topic in cardiac imaging. And interestingly, I never learned about this concept of coronary remodeling when I was in med school. Our current medical students learn about remodeling during 1st and 2nd year in histology and anatomy, and then it's pounded out of their brain 3rd and 4th year because they work with clinicians that teach them myth over and over. And yet, coronary artery remodeling, very, very important. What we all thought was that as plaques grow, they grow from the vessel lumen inwards into the vessel. It kind of makes sense, doesn't it? But in reality, what we now know is that during the majority of the life of a plaque, it doesn't grow into the lumen. The plaque actually grows outwards into the vessel wall, causing outward bulging of the wall, also known as coronary remodeling, and it spares the lumen. And as a result, on cath, it looks pretty, normal. All right? Also, on stress testing, this is oftentimes just a plain old normal stress test. All right? Angiography and stress testing give you no information about plaque composition and about remodeling. And yet, that's the predictive factors for vulnerability. So along comes new imaging modalities like coronary MRI and CT. And the benefit of some of these advanced imaging studies, the reason why they're getting so much press is not just because they're non-invasive, for the most part, but because they give you information not only about how much dye is going through the vessel, but they also give you information about the vessel wall. So for example, here's a guy that just had a negative nuclear medicine stress test. He goes for CTA, and what you see, this huge dark area, this is vessel wall with a plaque inside of it. Huge plaque sitting right outside the vessel lumen, and if all you did was cath, you'd only know about this mild occlusion of the vessel. Yet there actually is a huge plaque, very dangerous plaque, outside that vessel wall. Now, we'll talk more about CT later in the course, but I'm not advocating that CTA is ready to replace cath by any means. It's not yet the gold standard. But please remember that stress testing and cath are tarnished bronze at best. All right? So that's what we know. Okay, on to the guidelines, a little bit about the guidelines. Non-STEMI, and for the STEMI and PCI guidelines, they're very similar, so I'm going to run through quickly the STEMI and PCI guidelines, spend just a little bit more time on the non-STEMI guidelines. First of all, what is the most important symptom that patients have? Chest pain, of course, but please remember that 1/3 of patients that are having a proven MI have no chest pain, especially the elderly. By the time you're 70 years old, there's more than a 50% likelihood your MI will not be associated with pain. The most common angiola equivalent instead is shortness of breath. How many people here have a protocol at your triage where you get EKGs within 10 minutes of arrival if they have chest pain? Raise your hand up high. Should be everybody, right? Well, if it's an elderly patient or diabetic, please add shortness of breath to that protocol, because most of those elderly patients are not going to have chest pain. And if somebody shows up with shortness of breath, you should be getting EKGs just as quickly as if that patient came in clutching their chest, complaining of chest pain, or you're going to miss the MIs. All right. Over the age of 85, fatigue becomes the most common complaint. Has anybody here ever seen an elderly patient brought in for, I'm not feeling energetic today? Mom just couldn't get out of bed and make it to the bathroom. Dad just had no appetite this morning. Do yourself a big favor, get an EKG on them. I'm not saying they all need to be admitted, troponins, the whole bit. No. Just at the very least, get an EKG. You'll be surprised how often they turn up positive. All right? Over the age of 85, malaise becomes probably the most common anginal equivalent. All right? What are the most predictive factors on the initial evaluation? Coronary risk factors, family history, etc. Well, HPI, the history of present illness, and again, this is right out of the ACC/AHA guidelines. The most predictive factor in the evaluation in terms of whether somebody will rule in is your history of present illness. Cardiac risk factors have very limited value. Please don't ever send home somebody with a concerning story just because they have no cardiac risk factors. Right? The HPI trumps everything. So when you walk out of the room, if you're worried based on your history and physical, mostly the history, don't obviate your concerns just because they have no risk factors or just because they recently had a negative stress test or an unremarkable cath. All right, again, right out of the guidelines, folks. All right, serial EKGs and serial enzymes. If you open the door, now this is a controversial area, again, but this has to do with the risk management, okay? When you walk out of the room, you know, there's a lot of our patients, we just have a little bit of concern, okay? Getting an EKG is not a big deal. An EKG is practically an extension of the history and physical. But if you send off a troponin and you start the workup, once you open that door, the door doesn't close until after the provocative test. So if you're going to start the workup, you need to go all the way. And the guidelines say over and over and over that the workup needs to be done within 72 hours, all right? It doesn't say that you need to do the stress test in the hospital or in the ER, but it consistently says that if the patient's low risk and you open the door, that patient needs outpatient follow-up and stress testing within 72 hours, all right? There are no guidelines that will protect you if you send one set of troponins and discharge a patient and say, I'm done. All right? You can send off sets of troponins, EKGs, and then if you really think somebody's low risk, you can discharge them, but you have to verify that that patient's going to follow up within 72 hours. And that statement is made over and over and over in the ACC/AHA guidelines. All right? So, in other words, once you start the workup, you've got to keep that patient going until the provocative test. This is my Mr. Miyagi rule. You all remember the old version of Karate Kid. There's a new version of Karate Kid coming out apparently now. But remember, Mr. Miyagi sitting down with Daniel-san at the beginning of the training, and it says, Daniel-san, you know, man walk left side of road, okay. Man walk right side of road, okay. Man walk down middle of road, squish like grape. Karate, same, I can't do the accent. So karate, same way, right? Either you do karate or you don't do karate, but if you half-heart it, you're going to get squished like a grape. My corollary, okay, for ACS, same way. ACS do or ACS no do. ACS, squish like grape by these guys, okay? Once you open that door does not close until the provocative test. So you've got a couple choices here, all right? Keep this state in mind. We all are going to miss an MI. Has anybody here never missed an MI? Any liars out there? Okay, so good. So everybody's going to miss an MI. The standard of care is not to make every diagnosis. The standard of care is to do what's reasonable and supported by the literature. That's the standard of care. So, discharge after one set of enzymes and then you're done. That's not defensible. All right? Discharge purely based on a negative EKG or a recent negative stress test or angio, not defensible. Okay? That's the second most common cause of lawsuits that I'm seeing. Somebody sent off some enzymes and they say, oh, there's a negative stress test 3 months ago, so I'm done. Absolutely difficult to defend. Okay? Discharge without early follow-up, not defensible. So there's really only a few choices here. You're risk stratifying patients to either, I'm not worried at all, so I'm not going to do any workup and document why, or if they're low risk, you can start the workup and then make sure they get their provocative test at some point. That can be done in your ER, in the hospital, or it can be done within 72 hours, or if they're high risk, sure, you're going to send them to a cath lab, all right? But there are no protocols and no guidelines that say you can do one set of enzymes and then you're done. Please remember that, okay? That's not defensible. And again, part of what I'm trying to do is make sure that people can defend what they do. Right? If you send off one set of enzymes and that's it, patient goes home and has a bad outcome, it's more difficult to defend that case than if you never sent the enzymes and documented why and sent the patient home and they had a bad outcome. So I hope that point's clear. Again, very, very important. And there's just all too many cases that we see that are just very difficult to defend because somebody sent off one set of enzymes and never followed up, never verified that 72-hour follow-up. Okay, says, Your Honor, before we settle on judgment amount, we'd like to know how much money there is in the universe, right? You definitely don't want to be sitting in that courtroom. Okay, beta blockers. I hope people are pretty much on board with beta blockers. Beta blockers are pretty much out in the ED, all right? I learned, many of you learned, that when you've got chest pain, potential ACS, we give metoprolol, Q 5 minutes, 5 milligrams IV, Q 5 minutes times 3. We've all written for that many times during our career. And what the guidelines now say is that no IV beta blockers should be routinely given to ACS patients unless you have intractable hypertension. So your nitrates aren't getting their blood pressure down and they have extraordinarily high blood pressure. All right? IV beta blockers are out. You can give them orally, but the guidelines also say within 24 hours, not within the first couple of hours, okay? Because what you do when you routinely use beta blockers in ACS patients, you increase the risk of cardiogenic shock without increasing the survival benefit. Now, what are the risk factors for cardiogenic shock? If you have any of these conditions, you don't even give oral beta blockers within 24 hours. Age, systolic pressure, sinus tachycardia over 110, these are the very patients that we would most want to give beta blockers to. Well, what we now know is that if your ACS patient has sinus tachycardia, that's a risk factor for that person developing cardiogenic shock. And the last thing you want to do with those patients is to give them beta blockers, a negative inotrope, because you will hasten their transport towards cardiogenic shock. All right? Again, repeatedly mentioned in the guidelines. Again, class 3 means harmful IV beta blockers. Do not give IV beta blockers routinely in ACS unless you have intractable hypertension. All right? Oral administration and really, what we ought to do is just let the inpatient docs give the oral beta blocker 12 to 18 to 24 hours after arrival, because by then their hemodynamic status will have declared itself. All right? What about JACO? Everybody says, well, we're supposed to give beta blockers because of JACO's core measures. Well, you know what? JACO has never actually said beta blockers need to be given in the ED. If you look at what JACO has always said, give it within 24 hours. JACO has never said give it in the ED. All right? So this is something that should be relegated to the inpatient physicians. If you just defer use of oral beta blockers to 18, 24 hours, you get all of the in-hospital survival benefit without increasing the risk of cardiogenic shock. All right? So we do not use beta blockers for ACS in the ED at all. Our cardiologists are completely on board with this. And when we admit the ACS patient, they get the beta blocker orally after about 18 hours in the hospital. But if you routinely give it in the ED, all you're doing is you're increasing the risk of cardiogenic shock without the survival benefit. All right, antiplatelet therapy. Well, aspirin on board for everybody. If they're allergic to aspirin, you're going to give them clopidogrel. No debate about that. What about aspirin plus clopidogrel? Again, this is for many years, well, for about 5 years or so, been a topic of hot debate. And that's a completely separate lecture. But in terms of the guidelines, what you need to know, clopidogrel is really, really developing a lot of momentum. And so I think this may be something, there may be a fight that against clopidogrel that we've kind of lost. You know, it's kind of like 10 years ago, we used to battle streptokinase versus TPA. And we kind of, people just finally gave up and started using TPA for everything. And I think that's happening with clopidogrel. Again, shady evidence supporting routine clopidogrel, but all of the guidelines say give clopidogrel or an IV G2B3 inhibitor before they go to cath. All right? If you're not planning on cath, then forget the G2B3 inhibitor, give them the clopidogrel, 300 or 600, depending on your hospital protocol. All right? What about anticoagulants? Here's what the guidelines say. If they're going for invasive therapy within 24 hours, use whatever you want. Enoxaparin, unfractionated heparin, bivalirudin, or fondaparinux. If they're not going for invasive therapy, then take bivalirudin off the table. Enoxaparin, unfractionated heparin, or fondaparinux for your non-STEMIs. Use whatever you want. And discuss this with your cardiologist to see what they want. Fondaparinux will be favored if a person has a history of renal problems or heparin-induced thrombocytopenia. So that's the one time where fondaparinux really is going to be favored over the other choices. Okay, now switching over to, let's see, what else? Creatinine clearance, very, very important. All right? There's 3 groups of patients that are at very high risk for bleeding complications because of underlying renal insufficiency. Women, elderly, and patients with chronic renal insufficiency are at high risk for bleeding complications, and we have a tendency to overdose them on drugs like the G2B3 inhibitors and enoxaparin. All right? So if you have a female, an elderly patient, a patient with renal insufficiency, always take a look at their creatinine clearance and dose the medications based on creatinine clearance. Again, there's evidence saying that if you don't do that, you're increasing their bleeding risk, and we now have evidence showing that you're increasing their mortality as well. All right? What's the creatinine clearance calculation? You don't have to memorize it. Just Google search it. Any computer will pull up the Google creatinine clearance calculation. Then you enter the age, weight, sex, serum creatinine. And so here's a nice little example. All right? If you have an 85-year-old woman who's 110 pounds, serum creatinine 1.2, that all sounds pretty normal, doesn't it? But when you punch those numbers in, she actually has a creatinine clearance that's under 30, which means she has renal insufficiency, which means she needs enoxaparin and G2B3 inhibitors and any other medications that are renally excreted to be dosed based on renal insufficiency. If you don't do that, there's evidence showing increased mortality. All right? So always use a creatinine clearance for these particular types of patients. Okay, now switching over quickly, here's a billboard I think we should have in every city. Drive carefully, we have 2 cemeteries and no hospital. Okay. All right, quickly, the STEMI and the PCI guidelines, there's not a whole lot different. Beta blockers, everything I said for non-STEMI applies exactly the same way for STEMI patients for beta blockers, okay? Orally within 24 hours, if you simply defer use of beta blockers to 18, 24 hours, let the people upstairs do it, you get all of the in-hospital mortality benefit without the increased risk of cardiogenic shock. All right? So hold off on the beta blockers. Some people say, should I give some thrombolytics and then send them to a cath lab? That's something called facilitated PCI. A lot of people are really, really studying this intensely, and the answer is very simple, no. The guidelines, the data does not support facilitated PCI. All right? Facilitated PCI. What about half-dose thrombolytics or abscissumab and then send them to the cath lab? Well, the guidelines say maybe. They kind of fudge on this. Okay? So if your cardiologists like doing this, fine. But the data is very shady. Again, if you look at the data, class 2B, which means may be helpful, level of evidence C. All right? So talk to your cardiologist, but routine facilitated PCI, the data does still not support that. If you give how many people here use thrombolytics for your STEMIs? All right, so a handful. If you give thrombolytics and at the 90-minute mark, the patient is still having pain or still having persistent ST elevation, that's considered failed thrombolytics. Those patients definitely need to go to the cath lab, and that's called rescue angioplasty. And then in terms of anticoagulants for STEMI, the balance is tipping clearly in favor of enoxaparin. So non-STEMI, use whatever you want. For STEMI, people are pushing the enoxaparin much, much more strongly. For STEMI, people are pushing the clopidogrel much more strongly as well. And again, if they're going to the cath lab, 600 milligrams is the recommended dose. 600 milligrams clopidogrel, and then send them to the cath lab. If you have an elderly patient over the age of 75, there's no good data. So the guidelines really don't talk about use in the elderly. But if they're going to the cath lab, 600 milligrams, then send them to the cath lab. The guidelines still say, however, that it does not need to be given in the emergency department. You can do this, give this up in the cath lab. So talk to your cardiologist. If they want you to give it down in the ED, fine. If they want to wait until they get upstairs, that's fine also, okay? But it's not a requirement in the ED. Same is true for the G2B3 inhibitors. There's some protocols out there that very aggressively say, give them abscissumab and then send them to the cath lab. But if you want to do that in the ED, fine. If you want to let them go upstairs, that's fine as well. All right? Let's see, almost Girl Scout season. Keep this slide in mind when they come knocking on your door. All right? Okay, so real quick, let's just sum up. Quick summary. That took a little bit. So caffeine levels are building up. Okay, please beware diagnosis of reflux. If you only get one thing from my lecture, please let this be it. Okay? Please be careful about reflux. Over and over, lawsuits happen because somebody's calling it reflux. All right? Plaque size is out. Plaque vulnerability is in. And again, remember, cath and stress testing are not a gold standard. They are a tarnished bronze standard. HPI is the most important thing you've got. Non-STEMI, give them aspirin. Guidelines are more strongly favoring clopidogrel. Beta blockers, no rush. Let the folks upstairs give the beta blockers. Routine use of beta blockers in the ED associated with increased risk of cardiogenic shock. STEMI, beta blockers, once again, no rush. Greater emphasis in the new guidelines on enoxaparin and clopidogrel. And just discuss this with the cardiologist. What do they prefer? What do they want? All right? And also, please remember this also. If there's only two things you remember from this lecture, let this be the second point. If you start making a habit of using creatinine clearance instead of serum creatinine, in elderly, in women, and in patients with underlying renal insufficiency, you will save lives. It's that simple. You will save lives simply by punching into Google the creatinine clearance calculation and using that to dose the enoxaparin, the G2B3 inhibitors, and the other things. All right? So I'll be around if there's questions. I want to hand things over to Dr. Stamer. And again, thank you very much for having me and for your attention. Thanks.